All right, so non-invasive ventilation. All right, so we're doing different O2 modalities you can get up to, and not including intubation, but what can you do before you need to intubate somebody? Sometimes you just need to pull the trigger and it's time to intubate. So we'll talk about that in the rapid sequence intubation section, right? Where you have to, it's time to, they're not meeting criteria for these other O2 modalities, such as a Vapotherm is the brand name, right? Or BiPAP, which is also a brand name technically. All right, so they don't meet criteria for that. They need to go straight to intubation. But we have these other devices that we can use. These are called non-invasive positive pressure ventilation, because invasive positive pressure ventilation is a ventilator, right? Because we're invasively putting a tube down someone's throat and we are providing positive pressure ventilation, and it has its own consequences in of itself, which we'll talk about. All right, but we're talking about different O2 modalities you should be familiar with, like the cannula, face mask, etc. And then we're going to move on to some of the things you might not be familiar with, such as Vapotherm and BiPAP therapy. Okay. All right, so O2 delivery devices. So as you may or may not know, there's a formula to figure out how much FiO2 someone's getting. We know we need to improve someone's FiO2 if their PaO2 is low, and we can do that with two ways. We can do that with FiO2, right? Or what's the other way you can improve someone's oxygen level in their bloodstream? Beep. I heard it. There's like a little peep in the back. Beep, 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 beep. Right? So yeah, so PEEP and FiO2 are the two ways you can improve that. Do these devices here provide that at all? Absolutely not. Right? They are not providing positive pressure. That's all us, where all the patient's effort is what was providing the extra support or extra push behind the oxygen. The nasal cannula, it's up to them to take a big inhalation, right? For the non-breather, it's up to them to take a big breath in, right? But otherwise, these devices can deliver more and more FiO2, right? Like a cannula, what's the max rate on a cannula? It's false. It's max 30. You all the way up. It's going to start whistling, and it's going to be annoying. And you have to provide humidification if you're going to keep it there for any longer than an hour. But the max rate is as much as you need to, right? It's just going to whistle. You can't apologize for the glitches up there. But yeah, so nasal cannula, yeah, at 6 liters, we're probably going to consider do something else, right? Because the next step after cannula is a cannula plus, right, which is a simple mask, right? So simple mask would be next, right? If you're less than 6 liters on a simple mask, is that okay? No, that's called iatrogenic suffocation, right? Because the 6 liters is not washing out the CO2 that they are exhaling into that mask. They inhale oxygen, they exhale CO2. It's going to keep building up, and they're going to get sicker, right, or more comatose, let's say. Okay, so nasal cannula, simple mask. You can crank simple mask all the way up, but then we have non-breather, which is a more not resuscitative, but it's more of a temporizing measure. Provides about 80% to 100% FiO2, and even really just can't really get all the way up there. You can like plug a couple holes to make it get a little higher, and you increase the flow as much as possible on the flow meter, right? The little O2 flow meter on the wall. You know what I'm talking about? Little guy like that. It's on the next page. All right, it has different markings, different liters per minute on it. And those liters per minute, you can calculate approximately how much FiO2 someone's getting based on someone's average effort. If they have really, really weak effort, it's not exact, right? Because the patient has to provide that extra support to inhale the oxygen, right? So room air is what? FiO2? 21%, right? So 21% plus 4 times liters per minute is approximately how much FiO2 you're getting, all right? So if you're a nasal cannula at 6 liters or simple mask at 6 liters, how much FiO2 is that? What's 6 times 4? 24 plus 21, right? So about 45% FiO2 is how much a simple mask is giving you, okay? So these are all based on the patient's effort. Obviously, the more severe, right here. Obviously, the more severe someone's hypoxias or someone's hypercapnias, we might have to escalate to a non-invasive form, to a high-flow nasal cannula, such as this guy down here. It's also actually called a heated high-flow nasal cannula insufflation device, right? So, or Vapotherm if you're nasty. No, I'm kidding. If you want to support the big market, all right? So those are the ones that's the brand name, because there's such another brand name called OptiFlow, right? OptiFlow is another guy that produces these devices. There's also another one out there. It looks like a hood, right? It goes over the patient's head, and it looks like these little spacemen, right? So, but that's actually provides that little positive pressure ventilation. Okay, so O2 is delivered at a given liters per minute, and it's up to the patient to inhale that, right? And then we can actually provide extra support when more O2 is needed to help push the oxygen into the patient themselves, right? So we can dial that up. So on BiPAP therapy, CPAP therapy, we can actually go from 5 to 10 to 12 and higher. Usually for more than 10 support behind it, that's usually probably needs to be intubation territory. But we'll see if we can get them over the hump, right? Because some patients do a lot better not being intubated, such as a CPAP, a COPD patient, or a end of life patient, or a patient that has a lot of comorbidities. It's better not to put on the ventilator if we can avoid it. Okay. So devices, again, heated high flow nasal cannula insufflation device, or vapotherm, right, is the one we have here. And then we got CPAP or BiPAP, right? Those are the ones, there were two different modes you can program with the same machine, and that will deliver oxygen, FiO2. You just dial it in. You don't have to do any special calculations. It tells you exactly how much FiO2 you're getting based on also the flow you're putting behind it, okay? So these guys enable exact FiO2 delivery, which is nice, okay? Remember, a patient never requires more than 95% sat. That shouldn't be a thing, right? So if you are more than 95% sats, you're at the risk of being in toxic iatrogenic O2 toxicity, causing free radicals to form, causing all kinds of other damage to occur. Okay, so make sure that we are 95% or less, right? So 95% you can see equal to a PO2 of 80, but as you get further and further down, like 98% sats could be 250, right? So we don't know what that is. So we want to make sure that we are keeping it under 95, right? The exception, usually 80 to 92%. The exception being which kind of patients? Everybody gets 80 to 92% except for, your MIs and strokes. Then we'll tolerate 92, 94%, 92, 95%. All right. So yes. So who don't you want to suffocate with a chloroform there? Simple masks less than how many liters? Less than 6 liters, right? And non-breathers, again, they are temporizing, right? They are not, you should not get a patient from the ER on a non-breather mask. Like in RRTs, oftentimes we get called up and they've been on non-breather for overnight. It's like, well, no, we have to figure out another solution. We got to put them on BiPAP, vapotherm, something to figure it out, right? It's okay if you're like, they just got self-extubated and let's provide some more oxygen real quick, right? For an hour or two. But after that, it's a time to find another way to fix their oxygen problem or their CO2 problem. And how do you know which problem they have? You can do a VQ mismatch, or what else? They probably have a low VQ, or you can look at the ABG, right? ABG will tell you what they need and whether a vapotherm will be fine or BiPAP will be better, or maybe they just need CPAP, right? So we'll take a look at these devices right here in the middle. Our CPAP device / BiPAP and our vapotherm device. There are other ones out there like the Venturi mask. It was, sold as a cool thing. It has a jet engine devised by NASA engineers, but it's you have to you can't read the text written in the 80s. Those toys what happened, right? So you can't really see. They correlate to an FiO2 based on the size of the inlet on the bottom there. You got to switch them out, and they usually go to 60% anyways. So those can be used, but we have vapotherms now, and we have BiPAPs, CPAPs, which are a little more effective. Okay, so heated high flow nasal cannula device, so HHF&C, right? Our one we have here is called the vapotherm. There's such a thing as the OptiFlow as well. There's an OptiFlow device here. Looks like a huge cannula attached to the face, right? It delivers the FiO2. You tell it how much FiO2 I want. I want 40%, right? 40% right there. I want it to be delivering however much I program in. That's how much FiO2 it can deliver. And then behind that, I'm going to be pushing some oxygen, extra support behind that FiO2, right? So on this side, we got 35 liters of flow right there, right? We've got 35 liters of flow behind that 45%. Whereas someone on our simple mask, right, was 45%, but how much effort are they doing, right? So we're actually pushing that 45, that flow behind the FiO2, right? It's entrained. So there's air entrained into the FiO2. So if you look at the wall, there's a big yellow hose plugged into the yellow port of the wall, which is air. There's a green hose plugged into the green port, right? So it's entraining both of those in the machine and pushing what you tell it to push in, right? How much FiO2 is going to draw from the green hose and how much push from the yellow hose, right? So our vapotherms go up to 40 liters about, 40 liters per minute. It's going to crank it all the way up, and it's going to push 40 liters behind it, right? Behind that. Our OptiFlows go up to 80 liters, but then the sales rep for these guys are like, no, 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 actually 40 is the same as 80. It's like, okay, I don't know how you're going to sell me on that. But they say, oh yeah, our devices are designed by NASA engineers, and they also have this special and trained cannula, which has been designed through 10 years of market research and R&D. Okay, cool. All right, so yeah, 40 liters, I'm sure they do some studies to compare it. But either way, these are reducing the workload of the patient, right? It's helping push the oxygen into the patient, right? And then also these guys are saying, oh, they can increase the PEEP so much, but they're better than BiPAP. It's like BiPAP, you can actually get like 10 of PEEP, right? 10 of push behind, what we see on the ventilator, 10 of PEEP. We look at the BiPAP, there's a study in the BiPAP, which is just PEEP, right? CPAP of 10, EPAP of 10, or PEEP of 10. Those are all the same things. Now, does a vapotherm provide 10 of push behind it? It's like, well, 40 liters per minute, is that the same thing as PEEP? It's not, right? So I cornered the sales reps, like, well, how much PEEP is it? Right? Well, it's 0.7 per 10 liters. So you're telling me you only go to 40 liters. So 4 times 0.7, that's like 32, or sorry, 3.2 of PEEP, right? So you'd see in a ventilator, 5 of PEEP, it can't even push 5, right? So it can provide some PEEP, and it does, wash out some CO2 with how fast the flow is going, but it's not as good as a CPAP machine, BiPAP machine, or a ventilator, but it can reduce the workload on the patient and help blow off a little bit of CO2. But if we really want to blow off CO2, that's where we're going to pull out the big guns and get our BiPAP machine out, for instance. Okay, so here's a little liter flow I was trying to draw effortlessly on the previous slide, right? So you can push that ball all the way up if you need to. You can calculate how much FO2 they might be getting in a normal patient, but if we have a really sick patient, we really need to be in training the blue, green hose and yellow hose with a special device, such as our vapotherm, OptiFlow, or a BiPAP, CPAP, right? And our ventilators use it as well, right? So yeah, the other benefit of this guy is actually warms and humidifies the air as well, right? We can humidify our cannulas, right? Usually you have to humidify our cannulas when they're more than how many liters? How many liters? More than 5 liters, definitely you want to be humidifying. 5 or more, you want to be humidifying your oxygen, right? And that helps, support the membrane so they don't have epistaxis a day later, right? This guy is providing a lot of flow, a lot of push, a lot of oxygen, so it makes sense. It should be also heated and also humidified. That's why there's 2 H's here: humidified and humidified and heated. Okay. So that's the idea. It's more comfy, and it's also they can't hear you because it's so loud, but also it's going to be making it so they don't get dry membranes, and they're able to, have a somewhat normal function of what our turbinates do in our nose, right? Our turbinates heat and humidify the air going into our lungs. They are also our big, huge filters. Filters for what? Any kind of bacteria, right? It's our first line of defense against anything we inhale, right? So that's the idea. So there's the flow meter, which can get a approximate amount, but then we actually are going to start entraining air into the system and humidifying it and heating it so that we can then have a good flow of oxygen and extra push behind that oxygen. Okay, so CPAP and BiPAP. So it's done by the same machine right here. This Philips Medtronic, not Medtronic, it's Philips V60 or something like that. And again, our RTs are the mechanics of the world, of the hospital. They know exactly all the different machines, what they do, the different models, what kind of tires they take, all kinds of different things, right? So CPAP and BiPAP can be done by both of it. Both those modes can be done on this machine. And there's other different modes you can do as well. But we'll be focused on CPAP and BiPAP, right? So CPAP is, all it's doing is providing extra continuous, right, positive airway pressure. So if you take a big breath in right now, and then over that, you're breathing on top of that, that is CPAP. That's continuous positive airway pressure, right? You're not letting the pressure in your lungs get anything lower than 5 or 3 or 8 or 10, right? You're not letting that get anything lower than that, right? And that opens up alveoli, that opens up things so that O2 can exchange with those alveoli. Does it help CO2? No. The more alveoli you have it open up, yeah, CO2 can go into it, but CO2 needs to be exhaled, right, for you to get rid of CO2. This is improving oxygenation, right? So we're going to be improving someone's oxygenation by opening up more alveoli. If you have 10 alveoli versus 100 alveoli, you're going to be able to oxygenate a lot more pulmonary arteries than 10, right? So that's the idea behind CPAP, right? It's going to be opening up alveoli, preventing them from collapsing, right? Preventing lower airway collapse, atelectasis, emphysematous patients who are COPD patients. It's going to recruit alveoli and prevent those alveoli from collapsing, which is their kind of disease process, right? Their end of the bronchioles collapse when they exhale. So we want to keep that open at all times. It's going to help. Okay. It also prevents upper airway collapse in obese patients. It's going to keep those upper airways open at all times because the tissue of their body habitus can actually compress their lungs and cause air trapping and cause chronic hypoxia over time. So CPAP is great for these patient populations. The other downside in red here, it will increase intrathoracic pressures. All right, you're putting positive pressure inside the chest. That's going to impair the venous return coming from the toes, right? Going all the way up, it's going to try to return back to the right ventricle, right atrium, and it's not going to be able to do that effectively as your CPAP keeps clicking higher and higher and higher. And there's a certain amount, is like for every 10 CPAP, it's going to raise my CVP by 3. But so it's going to increase the pressure in my chest and impair venous return. Okay. And increased intrathoracic pressures can be extra work for the right ventricle. So if someone has like right ventricular failure or right ventricular MI, it might not be the best thing to provide to them. Okay. And then we got BiPAP, right? So BiPAP is providing it's called BiPAP because it's called bi-level, B, positive airway pressure. So it's not letting the pressure in your lungs get anything lower than a certain amount, just like CPAP, right? So CPAP is equivalent to the lowest mode on BiPAP called EPAP, right? So you set a expiratory positive airway pressure, say don't go any lower than 5. When they exhale, don't go anything lower than 5 or 3 or 7 or 10, whatever we set it at, right? And that is going to provide CPAP or oxygenation, right? So BiPAP is great at providing oxygenation, but also it has this other mode called IPAP, right? Or it's part of the mode. That's why it's called bi-level. So it starts at EPAP, starts at 5, let's say, and it goes all the way up to 12. And it goes which is your IPAP, your inspiratory positive airway pressure. And it goes all the way down to your expiratory positive airway pressure. Doesn't let it go any lower than that, right? So that's IPAP over EPAP. And we'll explain how that works and how it's going to improve things. But it's going to help ventilate someone, right? So if you have a EPAP of, let's say, 6, right, and you go to 12, that difference is a volume of some sort. So I start at 6, and when they take an inhalation breath, it's going to go up to 12, and that's going to pull that much volume. If I change it to 16 over 6, and it starts at 6, they go all the way to 16 over 6. That's going to be a bigger volume, right? So I have 16 over 6, for instance. That's a bigger volume, and we'll explain that on a slide here coming up. So this will help improve what? Tidal volumes, right? So we can control how much tidal volume someone gets, or we can impress upon the patient to take a bigger tidal volume. Sometimes you tell breathe, but they don't have good breaths, right? They have poor tidal volumes because of their disease process or whatever it may be. Okay, so IPAP over EPAP is the setting, and EPAP is the same as what? Same as PEEP, which you know from the ventilator. It's the same as CPAP, right? So CPAP is EPAP is IPAP. Or sorry, CPAP is the same as EPAP, just same as PEEP. IPAP is different. All right. So those things are all the same, and all any one of these 3 things in green here are going to improve what? They're improving your oxygenation, right? If we want to improve someone's ventilation, right, is when you ventilate, that means your inhalation, exhalation. That is the movement of air, which is moving what out of the body? CO2, right? So CO2 is being improved with BiPAP. So BiPAP improves ventilation, CPAP improves oxygenation. You could argue, yeah, BiPAP's also going to improve oxygenation. But the reason why we choose one or the other is because one's going to help blow off CO2, right? You always hear, let's get BiPAP, let's blow off the CO2. That's how it's doing it, and we'll illustrate that some more as well. Okay, so who gets indicated for BiPAP? They get respiratory fatigue, CNS disease, to help improve someone's tidal volumes. And also, if someone has poor oxygenation, we can use it as well. Okay, so this change in the pressures will improve your tidal volume up. If you make that change bigger, make the change smaller, it's going to reduce tidal volumes. Okay, whereas CPAP is all it's doing is improving oxygenation, right? CPAP, ZPAP is PEEP. They're all the same, right? Here's the example of the helmet I was talking about, right? It looks a little funky, right? But during COVID, they use it a lot, like in Italy. Okay, so these are what we're doing to improve someone's ABG. So in ABG, we see some oxygenation problems. How do we know they have oxygenation problems? The PO2 is low, pulse ox is low. We know there's a correlation there, right? So the PO2 is 60, their SpO2 is probably 90%. So if we want to improve that, all right, let's say they're 80% SATs and 70 PO2, we can improve that with which device? Trick questions, both. Our CPAP and BiPAP are both going to improve your oxygenation, right? But all you really need is CPAP, right? If you do an EPAP at 10 or a CPAP at 10, those are the same things, right, on both devices. But yeah, see, if that's all I really need to do is to improve someone's low SpO2 or low PO2, all I can do, I just throw them on CPAP. That will help. It's the same machine, so it's like, since I'm there, let's just throw you on BiPAP. But you're not wrong, right? But oftentimes someone says, oh, the PO2 is 50 this morning, and you go look at the BiPAP machine, and it's like 12 over 6. Like, really? Why don't we do 12? Why don't we do like 12 over 8, right? Why don't we try 14 over 10? Why don't we improve that low number, right? That low number is your EPAP, right? Or your CPAP. All right, and then if we want to improve someone's pH or the CO2, all right, that's ventilation. So which device only does this? BiPAP, right? BiPAP is the only one that's going to improve someone's CO2, right? And if the CO2 has caused the pH problem, we can try to compensate for them, but you know, there's some things where they might be too far gone on ABG or too far gone clinically where we have to eventually intubate the patient. Okay, so what are indications for BiPAP? Or in red there, what are contraindications? And just a clue, these contraindications are likely the ones that are indications for intubation, right? It's like, well, we can't try BiPAP because BiPAP is our last ditch effort before doing what? Going directly to RSI, right? So there are some times where you can't do BiPAP because it's time to intubate, right? We can try BiPAP on the sickest of sick patients as long as they meet criteria, okay? So who needs BiPAP? Those that are hypoxic, right? CPAP works here as well. Patients that have pulmonary edema and CHF, these guys, literature says that they actually benefit greatly from CPAP or BiPAP therapy. They will improve and turn around, and they have like flash pulmonary edema, and all the fluid goes in their lungs. It makes sense. We put more pressure in the lungs. It's going to open up more alveoli, and it might displace some fluid a little bit. It'll actually reduce venous return to the heart so that they can catch up, right? It actually improves preload, which we'll talk about on the slide here, and how PEEP is great for everything. And PEEP is the same thing as EPAP, the same thing as CPAP. So it's great for CHF patients that are just in distress. Okay, and of course you get a little Lasix just for free of charge too. Okay, improves survival dramatically when we put patients that are CHF exacerbation on CPAP or BiPAP, right? Someone has hypercarbia. That's only for which device? Only for BiPAP, right? You're not going to fix someone's CO2 with a CPAP machine, right? CPAP machine only provides PEEP or CPAP or EPAP. Okay, and COPD patients, right? They do get a retained CO2, so these guys are going to benefit dramatically from BiPAP therapy, right? Sometimes, they might not tolerate BiPAP. We can use Vapotherm in the meantime, right? It will, they compared them head to head and showed that yes, Vapotherm can reduce your CO2, equivalently because it blows off some dead space and such. But really, if you want to pull out all the big guns, that's your BiPAP's going to be the one that you can literally adjust, because it's up to the patient for Vapotherm for it to kind of work on its own, for them to have good breaths. Whereas on the BiPAP machine, we can keep widening the pressures between EPAP and IPAP and blowing off more volume, right? Improving tidal volumes. Okay, so COPD patients benefit dramatically from BiPAP, right? Research shows decreased mortality by 50%, right? So if you have two patients one by one, and you put both of them on BiPAP, or you say put one on BiPAP, you intubate the other one, right? The person that got intubated has a 50% chance of dying, right? So it's better to put the patient on BiPAP if they can tolerate it, right? So again, sometimes they meet the criteria for contraindications and it's too late, right? Obese patients, they benefit from this, right? Because I mean, you always heard, doctors that when they have to intubate someone that's really, really obese, it's gonna be hard because A, the airway is difficult to manage, but also B, it's better to, it's easier to extubate someone that's not obese than someone that is obese, right? So it's better to have this positive pressure while they're more alert on BiPAP to improve their outcomes, right? Immunocompromised patients don't do good on ventilators, right? They're risk for infections, you shut down defenses, so it's better to try CPAP or BiPAP therapy in that case, right? Do not intubate patients or end-of-life patients who would require intubation. Sometimes we'll try this to kind of get them over the edge. So it's, the next step is intubation. It's like, oh, no, they don't want that. They don't want to be put on life support. Let's try BiPAP. So it is one of our options in our toolkit. And then they realize that it's not the most comfortable thing to be on. Okay, so contraindications of BiPAP. So when can you say that, that we can't do BiPAP, we have to do something else, right? When is it time to, not get the BiPAP machine out, but go straight to intubation, right? So that's someone that's unresponsive, right? Unresponsive on BiPAP. If you've seen a BiPAP mask, it's blowing air into the face. It's like sticking your head out the window, a car window, going 60 miles per hour. Don't do that while you're driving. But if you're a passenger, you can go do this as long as there's no poles nearby. I saw a recent horror movie that happened. All right. Anyways, so that you can make it. It's not pleasant, right? If they're unresponsive, why is that an issue? It's like, no, I'm just gonna blow the air to them anyways. What's that?
They can't take it off.
They can't take it off, yeah. But it's also they produce saliva, right? How much saliva do you produce in 24 hours? 2 liters of squirt, right? So 2 liters you produce in 24 hours. You're blowing 2 liters of fluid down into their lungs, right? So there's 2 holes back there. There's esophagus too. Yeah, it's going to be blowing air into the airways, and that's 2 liters of fluid, right? So that's aspiration, right? So they're high risk for aspiration. So anyone that's risk for aspiration probably should not be on BiPAP in the first place. If they're unresponsive and on BiPAP, you're definitely blowing 2 liters of fluid down into their lungs, right? So you have like a really bad stroke patient who can't swallow, right? And you're putting, let's switch on BiPAP. It's like they can't manage the secretion to go down the esophagus. It's going to go down into the lungs, right? You have a myasthenia gravis patient or Guillain-Barré patient who can barely lift their head. They're blowing all these secretions down into their lungs, right? So it's not great. In the early stages, yes, it's good for those patients that have really profound weakness and fatigue. We can kind of get them over the hump. But if they really can't manage the secretions, it's time to put them on a ventilator, on doing a intubation, a rapid sequence intubation. So anyone that's unresponsive and anyone that's risk for aspiration, those are really the 2 key takeaway points. So who's at risk for aspiration? You can kind of see them, right? The copious secretions, they're vomiting. Why is vomiting bad? Because this could be a little Mars attack situation down here, right? So they vomit and it's gonna blow all that vomit back into the lungs, right? Which is not good. Right, and by the same token, someone that is restrained, right? So someone that's restrained on BiPAP and having a lot of nausea, vomiting, not a great idea. This is why they discourage you to have someone restrained on BiPAP, right? Because if they do have to vomit, they can't take the mask off, right? It's not against the law in California. It is in Arizona and some other states. It's very, very frowned upon in California, right? So what do you have to do in that case? If you do need to let's try BiPAP. You could try for 2 to 4 hours, see if you get over this. Right? And there's like, no, and they're pulling the mask off. So, and you want to restrain them. But what do you have to do in the meantime? You could watch them, right? Or you get a sitter can be there to encourage them to keep the mask on, right? And we can try Vapotherm, right? You can see if Vapotherm works, right? Sometimes it's not great, depends on their ABG and how bad it is. Okay? Inability to protect the airway we talked about, right? And inability to clear secretions are neuromuscular patients, such as our Guillain-Barré myasthenia patients, and then a severe upper GI bleed, right? That's probably not a great patient because these patients are high risk for vomiting in the first place. Blood is a irritant to the GI tract, all right? It's an irritant to the stomach, and they're going to be at risk for vomiting. So they have upper airway obstructions, right? They got a foreign body in there. They got angioedema. It's not a great time to use BiPAP. It's probably that's a unprotected airway that we need to go and put a tube through and intubate. Okay, facial trauma or deformities. You have to have a good seal on the BiPAP mask for it to work in the first place. Very, very unstable patients, right? You'll see a patient on BiPAP and they're like on 2 pressors. Like, well, that's what are we doing in this situation, because if you're on 2 pressors, you're probably requiring a lot of oxygen demand. And yes, the BiPAP will provide that, but there are also probably a lot of accessory muscle use and work of breathing, and it's better to have a ventilator in that situation. Okay, so that's the idea behind using BiPAP over intubation, or when it's time to intubate, because they have contraindications to being BiPAP'd, right? So there's a delay. You can't get the BiPAP in time. Sometimes we have 24 BiPAPs throughout the whole hospital, and like in the flu season, and we don't have enough BiPAPs. There's risk of aspiration, right? There's risk of injury, right? Pneumothoraces, sometimes they can grow, right? You don't know what caused a pneumothorax. Was it trauma, or was it like a bronchopleural fistula due to end-stage COPD? Right? We said COPD patients benefit greatly from BiPAP, but this might not be the situation if they have a pneumothorax is due to their COPD. Okay, and of course, they are not initiating breath. They're unresponsive. These are patients that are not that are not a good candidate for BiPAP therapy. Okay, so what are the benefits over venting? It's like, well, let's give it a shot. Let's try it. They don't meet contraindications. Let's give it a shot. And then someone else says like, oh, let's just intubate. Well, because again, we said COPD patients are going to benefit greatly. Immunocompromised patients will benefit greatly. Okay, when you intubate someone, is not free of complications. You can intubate someone, you can perforate the trachea, you can have a esophageal intubation, you can have a patient have a cardiac arrest in front of you, versus if we didn't go ahead and intubate, right? So there's all kinds of complications that can happen because of intubation. Okay, so sedation, when you give sedation to a patient, as we'll find out on our next lecture about weaning off sedation, the choice of sedation, sedation kills. So if you have too much sedation on a patient, it can cause problems. It can be another day on the ventilator, right? They can develop a ventilator-associated pneumonia, or they can develop a barotrauma over that next 24 hours, just because you kept them on sedation one more day, right? So you want to have just the least amount of sedation as needed to keep them calm. That's the idea behind sedation. And sedation itself causes hypotension. Besides keeping a patient on the ventilator for another day or 2 days or 3 days, it itself can cause hypotension. If you keep like propofol, for instance, for 3 to 5 days, and no one's checking triglyceride levels, that can cause pancreatitis, right? So whereas they would not have had a risk of pancreatitis before that point if we didn't choose propofol for sedation. It's a great sedative, but we have to make sure we're monitoring it. And the choice of sedation in our ABCDF bundle, the C, is the choice of sedation. Is it the right medication for this patient? Right? So if you do BiPAP therapy, you avoid that need, right? And there is one sedative we can use, which is like the bee's knees, is the greatest sedative invented in the last 20 years, that you can use outside of every other sedative, because every other sedative will cause respiratory depression and they have to be on the ventilator. What sedative did they not have to be on the ventilator for? Yeah, Precedex or dexmedetomidine, right? That's one that can be utilized off the ventilator, and it can be used for someone on BiPAP or vapotherm to kind of get them over this hump, get them over this flash pulmonary edema, get them over this immunocompromised pneumonia, this fever of unknown origin, right? Get them over this end of life situation, right? Or this, their end stage, multiple comorbidities, right? So we can try to avoid it if we need to avoid intubating, right? How do you develop a ventilator-assisted pneumonia? With a ventilator, right? So you can't get a VAP if you don't have a ventilator in the first place, right? So that's a benefit of using a BiPAP or CPAP, is there's no risk for VAP because you have a BiPAP therapy. Can they aspirate? Yes, and that's our job to monitor, right? And arguably, the patient that's on a ventilator is a lot easier than patients on a BiPAP, right? One, because they're probably pulling the mask off all the time, and you have to, the sitters watch them, but also they can aspirate really quickly. You got to make sure the pH, the O2 and CO2 is good. You got to make sure the settings are accurate, right? So they are actually the sicker patient, and oftentimes we give these to the newer nurses because like, oh, they're not as sick because they're on BiPAP, but they can easily deteriorate and require intubation, or they can they require close monitoring to make sure that we are fixing the right value. Are we fixing the O2 or are we fixing the CO2? And what are you supposed to monitor? Well, respiratory rate, right? The respiratory rate goes down, right? They're breathing, there is a backup rate on the BiPAP, but it doesn't, it's not going to be like a ventilator respiratory rate, which can actually control someone's CO2, right? But a respiratory rate and tidal volume, these guys are going to, you can look at the ventilator, at the BiPAP, sorry, and it tells you right then and there what your respiratory rate and what your tidal volume is. No longer is the respiratory rate 18, right? Oh shoot, it's 38. That's a really fast respiratory rate, right? And you can see the tidal volume in real time. Oh, they're getting 250, 350, 200. It's like, well, 200, I know it's not that great, right? That's a poor tidal volume. And how do I fix that? Well, I can change the settings to widen them out to get a better tidal volume, but sometimes they're just weak, and we can do all the effort with the machine, but they're weak and they can't, they need to be possibly intubated. So we've got to monitor the respiratory rate and tidal volume on our machine. ABGs, like we said, you're going to make sure the PO2, PaCO2 go in the right direction, right? So put someone on BiPAP with a CO2 of 96, and then you do an ABG 2 hours later, the CO2 is 110. It's like the BiPAP's not working, right? We need to then, at that point, intubate. Okay, and LOC, level of consciousness, the LOC is less and less and less. This happens classically where they have a sitter at the bedside, and then you go to look at the patient at 4 in the morning, and it's like, they're not waking up at all, are they? The sitter's like, no, they haven't been moved since it's like midnight. It's like, well, I haven't had to get up at all. And when I started my shift, they were moving all over the place. That's a problem, right? That's a decrease in LOC, which happens with a rise in CO2, right? So overall status and neurostatus, like we mentioned, but also, they might be getting more tachycardic or more bradycardic, and they might need to progress to being intubated. Okay, so what are red flags? What are reasons why you would say that it's time to intubate? And we'll touch base on this again with the intubation section, but their respiratory rate's not improving, right? Respiratory rate is 38. That's way too fast, right? If we can get them, kind of curtailed down to 34, 28, and we can keep them there under 30, fine. But if their respiratory is greater than 30, right, for 4 hours, 8 hours, a whole shift, it's probably time to intubate by the end of your shift, right? That's way too fast. The tidal volume, 250 is barely passable. If it's less than 250, no bueno, right? If the tidal volume is 300, 350, 400, not great, but it'll pass, right? And then we got to look at the ABG, right, to see if that is a good tidal volume, right? Because sometimes that might not be cutting it to get rid of the CO2 that they're building up. And their CO2 and pH don't improve, right? The CO2 starts getting higher and higher and higher, right? That's going to be a failure of their ventilatory drive, right? They're not ventilating effectively. And if the CO2 keeps going up, the pH is going to start going down. And sometimes the pH is going down because they're getting sicker on the metabolic side. It was the CO2 was the metabolic side, and if both are a problem, that's a mixed acidosis, right? So usually the pH less than 7.25, it's probably time to consider intubation, right? We can maybe try to turn it around with BiPAP, so give an hour, 2 hours to see if it improves, but usually that's usually territory to consider intubation. Depends on their mentation. If they're awake and alert, well, maybe they're a COPDer and they live at a high CO2. We talked about this last time, right? CO2 greater than 50 usually probably means intubation, right? The 50-50 club. But sometimes they live in the 50s, they live in the 60s, right? And how do you know someone lives in the 60s or 50s or 70s? What's a clue? PO2? No. PO2 and CO2 don't really bicarb. Good. So bicarb will tell you, all right, your bicarb is high. That means they were compensating a baseline to maintain that high CO2. The reason why they have the high CO2, it could be obesity, it could be a COPD patient with like emphysematic that's trapping air all the time, and that CO2 is building up over time, right? And we can take their bicarb, let's say it's 30, right? And you can punch it into this formula right here. It's called the Winters formula. And you just look it up, but it's 30 times 1.5 plus 8. And that is where their CO2 should be, right? 30 times 1.5, right? That's adding 15 to itself. So that's 45 plus 8. They live at 53 plus or minus 2. So they're sitting at 55. That's perfect. No problem, right? Let's take you off the BiPAP. You don't need this, right? So someone started BiPAP. Oh, CO2 is 55. Let's bring it down to 35, right? Well, if you bring it down to 35 and their bicarb is 30, how's the body going to compensate? The only way is to fix the excess base, right? Because now you have a basic 35 CO2 and you have a basic 30 bicarb. It's like, well, I can wait till tomorrow and get rid of some more bicarb with my kidneys, or I can do what? I can stop breathing, right? I can say, well, I'm going to reduce my respiratory rate from 20 to 8, right? And that's definitely going to raise my CO2 to balance this bicarb at 30. So that's why it's not great for COPD patients to overcorrect their CO2. You want to see what they are at baseline. And how do you know their CO2 retainer? And they should be at a higher CO2. You just eyeball the bicarb. If it's higher than 26, which is normal, then they probably are a CO2 retainer of some sort. Sometimes you'll see a bicarb like 40, right? They live like in the what? If their bicarb is 40, what should their bicarb be? Or sorry, what should their CO2 at baseline be? What's 40 times 1.5? 40 times 1 is itself, times 0.5, which is 50% of itself. You're adding it to itself, right? 60 plus 8, so it's 68 plus or minus 2. So 66 to 70 is where that patient lives if their bicarb is 40, right? And why do we not know that? Because we don't want it lower because they're going to stop breathing. If it's higher than 70, like it's 85, you can say, oh, no, Aaron told me their COPD or CO2 retainer, bicarb's high, so they must be a CO2 retainer. Well, that's too high, right? They are at a point where they have something else going on that's making them retain more CO2. So they should be on BiPAP until they get to 70. Then we take it off. They don't need it anymore. Okay, so that's the Winters formula. That tells you if they need, where their baseline PaCO2 should be. Other red flags, there you got poor mentation, confusion, agitation. We talked about that, right? They're getting more hypercapnic, more hypoxic, right? The agitation we can try with Precedex, right? We can try to abate it. We can try to get rid of it with these guys, with this IV agitation reduction agent, right? A anxiolytic. And also failure to improve. So sometimes if you live during COVID, right? So they had BiPAP for, they've been on BiPAP for 7 days. That's too long, right? The literature before COVID and after COVID still says 24 hours, right? So if you come in and you get reports and you say, oh, they've been on BiPAP for 2 days. It's like, well, today's the intubation day, right? Because or it's the goals of care discussion today. So we got to say, grandma's not doing better. She's been on it for 2 days. You guys want to consider, full support where we intubate, put in life support, or are we going to, take this mask off? Or do you want to continue it and hope for the best, but we have the risk for aspiration and these other risks, right? So usually BiPAP more than 1 day, it's usually time to intubate, okay? Oftentimes also you take the BiPAP mask off and they desat down to the 70s, that's someone that needs to be intubated, right? That's not someone that's going to be fixed with BiPAP, okay? So routine care with these patients, still do oral care Q4 hours because if you have to intubate the patient later, that's going to be a desert and it's going to be all crusty and the airways, there's many airways that got occluded because of these dry, thick secretions and the patient's code because of it, right? So you have to do oral care Q4 hours not only for that reason, for the end result and end game, but also for patient comfort, right? They're always, have dry secretions, right? So titrate off BiPAP, they're doing great, right? They're awake and alert and they're doing good. You look at the ABG this morning, CO2 is going the right direction. We can try to titrate them off BiPAP, right? Work with the providers, we drive 4 hours on, 4 hours off, right? And to get them titrated to just high flow days cannula. And then you're still monitoring to see if they are decompensated or not. You're still monitoring, the respiratory rate. You can't monitor tidal volume on a vapotherm, but you can monitor LOC, you can monitor ABGs, you can monitor their overall status, right? Are they going to AFib RVR? Well, shoot, let's put you back on BiPAP, right? And you want ABGs at least daily if someone's on BiPAP. That's going to let you know if you're going the right direction. The pH is getting too low, the PO2 is getting too low, CO2 is getting too high. These are reasons that we would consider, going towards intubation or not. Okay. So quickly, how do you normally breathe? So this is the normal respiratory process, all right? So movements of things in the universe go from where to where? Everything in the universe goes from high to low, right? So if you have high sodium on one side, it's going to go to the area of low sodium on the other side, right? You have high water on one side, it's going to the area where there's low water on the other side, right? That's called osmosis. Previous process of diffusion. This is the ventilation, right? Your normal respiratory cycle. And your body creates a high pressure inside the chest, right? When the diaphragm goes down, right, that's going to create a high pressure inside the chest, and therefore air is going to want to go from outside. Sorry, I said that backwards. So when you increase the volume in a chamber, right, it's called Boyle's law. That's going to reduce the pressure inside that container, right? So when a diaphragm goes down like this, the pressure outside is still the pressure outside, but you just reduce the pressure inside the chest because your diaphragm went down. So air goes from outside to inside. And then vice versa, we're going to, we exhale, we're going to make the pressure inside the chest get higher, right? Just like a piston on a car, right? We reduce the volume, that's going to increase the pressure inside the chest, and the air is going to want to go from inside the chest to outside the chest. The reason I bring this up is because this is what explains how BiPAP modes work. Our waveform is going to look like this on the monitor, and also our ventilators. So we're able to see the waveforms. Oh, that's where they took a little breath, right? Because we create a negative pressure or positive pressure initially when we inhale. We create a negative pressure, right? So when I misspoke, that was a mistake. I self-correct because, oh, no, you create a negative pressure first, right? So your diaphragm goes down, makes the volume in the chest go up, right? And that increased volume is going to reduce the pressure overall in the chest, right? So if we look at this patient right here and we ventilate them, right, the air is drawn in, right? So the air is drawn into the chest because the diaphragm went down. You see the diaphragm in the bottom right corner went down. The air all got drawn in, and then we are going to ventilate again, and we exhale, right? So that's the idea. So air is drawn in because we create this negative pressure. We pulled down the diaphragm, we created a low pressure, and air is going to be drawn into the chest until it equilibrates, right? And then we're going to forcefully exhale. We're going to push the diaphragm up, right? And that's going to make the air leave, right? And then we're back to square one. So that's the idea behind inspiration and expiration. That's the normal process, right? So we look for this on the ventilator. We look for this little drop in pressure, right? And the ventilator looks for it too, and the BiPAP machine looks for it too. So they're taking a breath. Let me, and they're going to do positive pressure at that point, right? So they're able to support the patient and work with the patient whenever they take a breath, right? And the RT can go in there and change that trigger. They can make it less sensitive or more sensitive. Okay, so that's the idea behind normal ventilation. Okay, so this is another explanation.
Let's talk about an open pneumothorax. So as you can see here, we have our lung in the bottle here. And so we know that when we are ventilating, inhaling and exhaling, we're manipulating the thorax pressure, the pleural space pressures, and creating negative pressure to inhale and exhale, as you can see. Inhale, exhale, inhale, exhale. But if we have an open thorax, so I just created a little hole here that manipulating our open pneumothorax, an open pneumothorax. And so look what happens when I try and deflate, when I try and inflate that balloon. I can't create any negative pressure in the pleural space. And if I can't create any negative pressure in the pleural space, then I'm not able to inflate this lung appropriately. That's going to be a big problem. So that's why we want to try and seal it and make sure that we can create negative pressure in order to inflate that lung again. That's how an open pneumothorax can be a real big problem if we're not intervening.
Okay, so that's the idea. That's the importance of maintaining that negative pressure inside the chest at all times, so you can actually draw breath in.